Evening. Today we will continue our lectures about hereditary disorders affecting the kidney, and we will talk about two closely related conditions, Alport syndrome and thin basement membrane disease. This is our agenda. What is the similarities between Alport syndrome and thin basement membrane disease is that both of them is due to defect in the basement membrane structure, and the main presentation in both Alport and thin basement membrane is persistent hematuria. This is very important. They share this, that the cause is basement membrane abnormality, and the main clinical feature and the main presentation is in both conditions is persistent hematuria. First of all, we'll talk about introduction about Alport syndrome. Alport syndrome is an inherited disorder, as we said, in basement membrane structure caused by mutation in the genes for type 4 collagen, genes. The major features of Alport syndrome or the major clinical manifestations include kidney affection, ear and eye abnormalities. So it is systemic disease. Kidney, usually leading to CKD and end-stage renal disease. Ear affection in the form of sensory neural deafness, and ocular abnormalities, as we are going to say. It is a rare disorder affecting around 1 in every 50,000 people, and the Alport syndrome accounts for around 0.5% on all end-stage renal disease adults, and around 1.7% for children with end-stage renal disease. What about the thin basement membrane disease? It is autosomal dominant inherited disease, autosomal dominant, usually in a familial condition, and the main presentation is microscopic hematuria, but it differs from Alport syndrome that other renal affection is very rare. There is no proteinuria. Usually there is no renal impairment. So it is called a benign familial hematuria. Only hematuria, no proteinuria, no renal impairment, and no extrarenal affection. And it is a very common condition. Now we'll talk about the etiology and pathogenesis, but before we will talk about, with some focus about type 4 collagen, which is the main abnormality in both conditions. Type 4 collagen is a major component or a major constituent of the basement membrane in glomerular basement membrane, Bowman's capsule, distal renal tubule in the kidney. So in the kidney, it is mainly present the glomerular basement membrane, Bowman's capsule, and distal renal tubule, and it is also present in the skin, in the epidermis, eye, ear, and testis. From here, you can know the clinical manifestations of the and the abnormality in Alport syndrome, as we said, in the kidney, in the eye, and ear, because type 4 collagen is present in all of these. Type 4 collagen proteins is composed of 6 chains, and they are named or designated as alpha 1 to alpha 6. Alpha chains, 6 alpha chains from alpha 1, 2, 3, 4, 5, 6. Alpha 1 to alpha 6. What happens in Alport syndrome? Alport syndrome, as we said, there is a defect in type 4 collagen, but Alport syndrome, the inheritance is varied. We have 3 types of Alport syndrome, or 3 modes of inheritance. X-linked, which is the most common and accounts for 80% of cases. These numbers are very important and they are frequently asked for. The second form or the second inheritance is form of inheritance autosomal recessive, accounts for 15%, and autosomal dominant accounts for only 5%. In X-linked inherited or X-linked form, which is the most common one, the abnormality is in alpha 5, in alpha 5 chain. In the three types, the abnormality in the type 4 collagen, but the difference in which chain, as we said, there is from alpha 1 to alpha 6. The abnormality in X-linked disease is the mutation in the gene encoding for the alpha 5, so it's called type collagen 4, A5 for alpha 5 chain. While in the autosomal recessive and autosomal dominant, the mutation is present for the alpha 3 and the alpha 4 chains, alpha 3 and alpha 4, and it is present in chromosome 2. In chromosome 2. This is very important slide. What about thin basement membrane disease? Thin basement membrane disease, as I said, it is usually autosomal dominant and with a familial presentation. We have a positive family history, and in 40% of families have mutation in alpha 3 and alpha 4, A3 and A4, coding for the alpha 3 and alpha 4 chains of type 4 collagen. Also the affection type 4 collagen for the alpha 3 and the alpha 4 chains. This mutation leads to the male pathology in thin basement membrane. From its name, the basement membrane, the glomerular basement membrane is very thin. The normal thickness of the glomerular basement membrane is around 350 nanometer, but in thin basement membrane it is less than 200 nanometer, as we are going to see in a few slides. Talk about the clinical manifestations of both diseases. We will start by Alport syndrome. As we said from the start, that both Alport and thin basement membrane disease present with persistent microscopic hematuria, and it is the main clinical presentation. As we said, in Alport, there is affection of the kidney and ear and eye. The kidney affection, the main kidney affection is hematuria. It is usually the first presentation and the most important one, but there is also proteinuria, which is progressive with age. With increasing age, proteinuria increase, and it can reach to nephrotic range proteinuria. Also, blood pressure increases with age, and it reach high blood pressure values. And there is progressive renal impairment. This is very important. Progressive renal impairment with age, and reaching end-stage renal disease in all males with X-linked disease. X-linked is the most common form. It is present in 80%. So it is X-linked, so it is more common in male patients, and all male patients will reach end-stage renal disease usually by the third decade. The ear affection is usually in the form of high-tone sensory neural deafness, which is present in most of the cases, usually present in the second decade. By adolescence, it became very obvious. And the eye affection, we have three affections, three common affections in the eye of Alport syndrome patients. The most important one is the anterior lenticonus. It is pathognomonic of Alport syndrome. What is anterior lenticonus? From its name, it is affection of the anterior surface of the lens with cone distortion, cone-shaped distortion of the anterior surface of the lens. It is pathognomonic of Alport syndrome, and it leads to distorted vision. It also became obvious in the second decade. X-linked females are not very benign. Usually also have progressive proteinuria, and usually they can reach end stage and end stage renal disease in 10 to 15% of patients. So 10 to 15% of females with X-linked affection reach end stage renal disease. What about the autosomal recessive? The autosomal recessive has a similar clinical feature and similar clinical scenario and history, natural history, like an X-linked males. So it is also aggressive, but the autosomal dominant usually has a more benign and milder course. Some families with Alport syndrome have associated leiomyomatosis of the esophagus and trachea, some with genital leiomyomas and clitoris hypertrophy. These are the eye abnormalities in patients with Alport syndrome, the famous anterior lenticonus abnormality. Second is maculopathy or flicks, and the third abnormality is called corneal endothelial vesicles or posterior polymorphous dystrophy. These pictures are usually present in every exam for the master or MD of nephrology or in the European examination. This is the anterior lenticonus. This is the cone-shaped slit lamp examination, the cone-shaped abnormal distortion of the anterior surface of the lens. And this is maculopathy. Here we found whitish or yellowish flecks in the perimacular area. Anterior lenticonus is usually associated with it will affect the vision, but in maculopathy usually it doesn't affect the vision. And both of them are usually became very evident in the second decade of life or within adolescence. What about the clinical manifestations of thin basement membrane? It is very simple. As we said, thin basement membrane, then the only presentation is microscopic hematuria. They only present with microscopic hematuria. It is a diagnosis of exclusion. And don't forget this note. Around 25% of all patients who present with microscopic hematuria to renal clinic, 25% are due to thin basement membrane disease. So quarter or 25% of all patients with hematuria in your clinic is due to thin basement membrane disease. Again, and a main differentiating point with Alport, in thin basement membrane disease, there is no proteinuria, no hypertension, no renal impairment, no extrarenal manifestations. Very important points. What about the diagnosis? What about the diagnosis? Very crucial part of our lecture. We'll start because we will need this in the next slide. What about the immune staining of type 4 collagen? Type 4 collagen, as we said, we have we have 6 chains, alpha 1, alpha 2, up to alpha 6. But the abnormalities or the mutations here with us are due to either alpha 5 in X-linked form of Alport, autosomal recessive, and in autosomal dominant it is in alpha 3 and alpha 4. In our practice to reach a diagnosis of Alport syndrome, usually it is very likely to depend on the skin biopsy. Skin biopsy is much less invasive than renal biopsy. In normal patients, normal population, look at this as I'm highlighting alpha 5 staining of type 4 collagen is present in the glomerular basement membrane, and in the skin, the epidermis, normally it is present. Alpha 5 of type 4 collagen, normally it is present in the skin. But in X-linked males, which is the most common form of Alport, it is absent. It is absent. In autosomal recessive, it is present. Again, if we do a skin biopsy, if you have a patient with hematuria and the proteinuria, and you want to diagnose patient and you suspect Alport syndrome, how to differentiate between X-linked and autosomal recessive? In X-linked, in the skin biopsy, the staining for alpha 5 chain and type 4 collagen is absent, but in autosomal recessive it is present. Don't forget this. In X-linked female, remember one word: mosaic appearance. Mosaic appearance, very characteristic for the X-linked females, for females with X-linked disorder. But for the X-linked males and autosomal recessive, it is absent in the skin and it is present in the epidermis. And if you focus here, you will find that in X-linked males, alpha 5 is absent in all areas. The glomeruli, Bowman's capsule, and distal renal tubules, but in autosomal recessive, it is only absent in the glomeruli, but it is present in all other areas. It will become positive. It is present in the Bowman's capsule, distal renal tubule, and epidermis. A very important differentiating point to differentiate between X-linked and autosomal recessive. In X-linked male, which is the aggressive form, it is absent in all areas, but in autosomal recessive, it is only absent. I am talking about the alpha 5 type 4 collagen, alpha 5 chain. It is only absent in glomeruli, but it is present in all other areas. This to differentiate between both of them. Talk about how to differentiate or how to diagnose Alport syndrome or thin basement membrane disease. What is our diagnostic approach? Usually, we'll start that patients have hematuria. As we said, the patient will present by hematuria. The first thing is to look or to check if there is proteinuria or there is a family history of end-stage renal disease. If there is no proteinuria and no family history of end-stage renal disease, the second step is audiogram. Audiogram. If it is normal, you suspect thin basement membrane. If it is abnormal, you suspect Alport. Suspect. The next step is ophthalmic examination. Usually, we doesn't need that because if the audiogram is negative, mostly it is thin basement membrane disease, and you confirm that when we do skin biopsy and with staining immunohistochemistry for alpha chain of type 4 collagen, it is normal, and then it is straightforward, mainly a diagnosis of thin basement membrane. But if we have abnormal audiogram and abnormal ophthalmic examination, and it revealed slit lamp examination, it revealed anterior lenticonus, and we do skin biopsy for alpha chain type 4 collagen and it is abnormal, so it is a diagnosis of X-linked Alport syndrome. X-linked Alport syndrome. The second scenario is that to have patient with hematuria but no proteinuria, but there is a family history of end-stage renal disease. In this case, you should ask for audiogram, and it will be helpful. But in some cases, if it is too early in a child, it might become not evident in the very early stage. We said that the audiogram, we found the deafness or the sensory deafness. Usually it became evident by the second decade of life. So in very early years, it might be normal. Also, we should ask for the slit lamp examination and for ophthalmic examination. If there is abnormality, it will support the diagnosis of Alport. But if we still not sure, we should do skin biopsy, as we said in the previous slide, and stain for alpha chain. As we said, in X-linked, it is the most severe. Alpha chain in X-linked males, it is absent in all areas, in the glomerular basement membrane and Bowman's capsule and in the epidermis. So in the epidermis, it will be absent. But if it is normal, as we said, it might be normal patient or autosomal recessive. So in this condition, we will need kidney biopsy to differentiate between normal and autosomal recessive patients. Autosomal recessive patient. We should stain for alpha 3, alpha 4, and alpha 5. In X-linked, all are absent. In X-linked, alpha 3, alpha 4, alpha 5, they are absent in all areas of the kidney, in the glomeruli, Bowman's, and distal renal tubules. In autosomal recessive, it is absent. They are absent, all of them, in the glomeruli, but they will be positive, and it is a differentiating point. The alpha 5 will be present in the Bowman's and renal tubules. So in the third one, it is like this. If we have a patient with proteinuria and family history of hematuria, we should ask for audiogram, then for slit lamp examination, and then for we should suspect Alport, ask for skin biopsy and immunohistochemistry staining for alpha 5 if it is abnormal. So it is a diagnostic for X-linked Alport. If it is normal, then we should do renal biopsy with staining for alpha 3, alpha 4, alpha 5. If they are all absent, so it is absent in the if they are all absent in all areas, so it is X-linked. If they are all absent in the glomeruli, but the alpha 5 is positive in the Bowman's capsule and in the distal renal tubule, so it is autosomal recessive. What about the pathology? In renal biopsy in Alport syndrome, we start by the light microscopy. Light microscopy is not conclusive, or there is no pathognomonic lesions in Alport in patients with Alport syndrome. Usually, light microscopy reveals mesangial hypercellularity and matrix expansion, with some forms of focal segmental glomerulosclerosis and interstitial fibrosis and tubular atrophy. There is no pathognomonic lesions. But the most important is the immune fluorescence. Immune fluorescence in patient with X-linked needs and autosomal recessive. As we said before, in X-linked males, which are the most common form, alpha 3, alpha 4, alpha 5, and we ask for immune staining for the type 4 collagen, they are absent in the glomeruli, absent in Bowman's, absent in the distal renal tubule or the tubular basement membrane. But in autosomal recessive form, alpha 5 is absent in the glomeruli, but they are present in the Bowman's capsule and basement membrane of renal tubules or the tubular basement membrane. This is the main differentiating point. Again, in X-linked, they are absent in all over the kidney, but in autosomal recessive, they are absent in the glomeruli, but present in the Bowman's and tubular basement membrane. And as we said, in X-linked females, don't forget mosaic appearance. It is characteristic. They give a mosaic appearance. This slide is very nice, illustrating the immunohistochemistry in Alport syndrome. In the above pictures, it reveals the alpha 3, alpha 4, and alpha 5 chains of type 4 collagen. In the above pictures, it is a normal glomeruli. All of them are present. As we said here, it is very obvious. It is normally present in all the alpha 3 and the alpha 4 and the alpha 5. But in the lower pictures, they are absent. Alpha 3 absent, alpha 4 absent, so we should suspect Alport. Alpha 5 is the main differentiating one, between X-linked and autosomal recessive. If alpha 5 is absent in the glomeruli and basement membrane tubules, so it is X-linked. But if you look here, you found it is positive in the Bowman's capsule and tubular basement membrane. So in this picture, we have negative alpha 5 chain in the glomeruli, but positive in the Bowman's and distal renal tubule. So we have a case of autosomal recessive Alport syndrome. This picture is very nice. What about the electron microscopy of Alport syndrome? We said light microscopy is not pathognomonic, and immunohistochemistry is diagnostic of Alport syndrome, and also electron microscopy is diagnostic of very characteristic features of Alport syndrome. What are the diagnostic features of Alport syndrome in electron microscopy? It reveals variable thickening and thinning of the glomerular basement membrane, gives a characteristic basket weaving appearance. Don't forget this word, basket weaving appearance, and lamellation of glomerular basement membrane, as we're going to see. So again, there is thickening of basement membrane with areas of thinning, and basket weaving appearance and lamellation of glomerular basement membrane. These are the characteristic features in electron microscopy in Alport syndrome. Thick segment, it reaches up to a very thick segment. It reaches up to 1,200 nanometer. The normal glomerular basement membrane thickening is around 350. So it reaches a very thick diameter with irregular outer and inner contours. The lamina densa is transformed into a network of membranous strands that gives the characteristic lamellation of the glomerular basement membrane. But take care that not all Alport subtypes give these characteristic ultrastructural features. Also, this picture is very important, frequently asked for in the exams. This is a normal glomerular basement membrane. Look for the thickness here. And for the food processes, they are very healthy. This is the Bowman's space. This is the capillary lumen. Look for the thickness of the basement membrane here, and this for the healthy appearance of the food processor. But let's look for the Alport syndrome. Look for the thickness here in Alport syndrome. It's very thick compared to this. Very thick glomerular basement membrane, and look for the lamellation of the lamina densa, as we said. Lamellation, it is present all through this characteristic lamellation of lamina densa, and look for the food processes. They are not healthy at the Bowman's site, Bowman's space site. What about thin basement membrane biopsy? Light microscopy and the immune fluorescence in thin basement membrane are unremarkable. They give normal appearance and normal tube type 4 collagen staining, very normal, and thin basement membrane is only diagnostic by electron microscopy. It will give diffuse thinning of the glomerular basement membrane. So thin basement membrane is only diagnostic in renal biopsy by electron microscopy, diffuse thinning of the GBM and lamina densa. And the width of the GBM is age and gender dependent. Typically, a value of 250 nanometer is a differentiating point between, or a differentiating cutoff between normal and patient with thin basement membrane disease. If it is above 250, mostly it is a normal GBM, but if it is less than that, so it is thin basement membrane disease. For children, the cutoff is between 200 and 250. Don't forget these numbers. Also, this is very nice picture. This is the normal GBM, normal thickness in GBM, and look at here for in thin basement membrane. It's very thin compared to this. Both are with the same magnification, if you are asking. Both are with the same magnification, but look here, the thick, and here it is diffuse thinning all over, diffuse thinning all over. What about treatment? In Alport syndrome, no specific treatment is an inherited disorder. So, and all male patients usually progress to end-stage renal disease, as we said, in X-linked males usually progress to end stage by the third decade. In X-linked female, usually around 10 to 15% will reach end stage by the age of 50. So what we can do is good control of blood pressure. We can use ACE or ARBs with that will lead to proteinuria reduction. This can delay end-stage renal disease. So good control of blood pressure and proteinuria. Family members should be screened, of course, for hematuria and hypertension. What about transplantation? Transplantation usually is successful in Alport syndrome, but take care of a rare condition that occurs after transplantation in Alport patients is the occurrence of de novo anti-GBM antibodies. De novo anti-GBM antibodies that can cause rapidly progressive glomerulonephritis. We are mostly because the type 4 collagen is recognized as non-self. The alpha 5 type 4 collagen is usually not present in that body. So with the new kidney, it is recognized as non-self. That leads to the formation of de novo anti-GBM that usually cause RBGN, especially in the first year, and this occurs in less than 5% in around 2 to 3% of all transplanted patients, of all Alport patients who do transplantation. Don't forget this number. It is only present, it is a rare condition, it is only present in less than 5% of all Alport patients who did transplantation. Thin basement membrane patients should be reassured, but don't lose the follow-up. Follow-up is important in these patients because there is very small risk for renal impairment that can occur only in less than 5%. So what we can do, regular follow-up, annual follow-up by urine analysis and the blood pressure measurement and renal function assessment. So reassure, but do follow-up annually. To summarize, the differentiation between thin basement membrane and Alport syndrome is the extrarenal abnormalities. They are present in Alport, in the ear, in the form of deafness and the eye, anterior limb conus and maculopathy, proteinuria and hypertension and CKD and end-stage disease are present with Alport but not present with thin basement membrane disease. The gender difference is present in Alport syndrome. As we said, the most common form is the X-linked, so it is more common in males than females, and this is not present with thin basement membrane disease. And of course, the mode of transmission or inheritance in thin basement membrane disease, it is autosomal dominant, but in Alport it is X-linked in 80%, 15% autosomal recessive, and 5% autosomal dominant. Thank you, and this is our resources. Thanks.